Okay, here we go. All right. Can you guys see my first slide? Because I don't have an EA if anybody
Yes,
to
we
help run
can.
my slides.
Yes.
All right, great. All right, great. So the art of gynecology. So, you read books, right? You read articles, your friends tells you something, so a piece of information, but kind of how, like, what's the right way, right? And so I call when I'm giving lectures, I call them the art because, coming straight out of medical school, you kind of learn what the book tells you to do, but you haven't really mastered the art. Just that everyone is probably a master of what they do. I really am very good at gynecology. And I think I explain it well, I break it down well, I keep it real. We're gonna have some laughs. And again, this is really, really informal. So please be comfortable to be vulnerable. Please be comfortable to ask questions. If we need to talk afterwards or online, I'll put my cell number in the chat. You all can Teams message me, whatever you need for further information. Okay. So menopause, obviously, we see it can look like anything. It can happen to anyone, any woman. It doesn't matter what ethnicity you are. It doesn't matter where you are from, where you were born, where you live. At some point in your life, if we are female, we are all going to go through this time where our bodies and our ovaries stop working. And that can manifest, many, many, many different ways. And, commonly, we'll see, have a patient, maybe let's call her like menopause lady, she's 48 years old, and she may have complaints. She's got kids and she's complaining of hot flashes, mood changes, she's anxious, she's snapped at her kids a few times. She's tired. She's fatigued. She's not feeling herself. She can't focus. She can't remember things. She's not sleeping. All these multiple complaints. She really sometimes may feel like she's just going crazy. Like, I am not myself. This is not myself. And typically, we kind of are really just comfortable and familiar with thinking of menopause as hot flashes, or we're thinking of it as night sweats. And if we don't have those things, we think, oh, well, this couldn't be it. But I want to talk about all the various symptoms of menopause that woman could experience. And you may find that you may say, oh, that's me, right? So menopause, this is a really cute picture. All of these different associated words that we have with it, irregular periods, our bones, vaginal dryness. We'll talk about menstrual cramps, bone thinnings, urinary infections or urinary frequencies. There's all these different kind of symptoms. And so let's spend some time and go through those. And I want to tell you again, you are not crazy. Um, but let me just kind of describe what these symptoms may actually manifest in your day-to-day life. Okay. So hot flashes, obviously, very common. You may experience a hot flash as like your chest or your face may get hot and then it may just kind of expand all over your body. You may feel like the temperature, like someone just literally turned the thermostat up. You may be in a meeting talking, and that might be beads of sweat that break out over your forehead, or your shirt starts getting wet. You wish that you could just take off all of your clothes, your shirt at least unbuttoned. You may have a fan, and this may last, for a minute or 2 minutes or 5 minutes, and then it may go away, and then you get cold. You may happen one time a day, it may happen 5 times an hour. Everybody is very different. And then when it happens at night, it's called a night sweat. So you wake you up out of your sleep, you take off the covers, and then you start taking off your clothes. And then you like lay out in the bed like in an angel position, and you just want the cool air to blow over you, and then a few minutes later you get cold, the covers come on, you may have one foot hanging out the bed because you're still kind of cold. So that's a night sweat, and it disturbs your sleep. And so let's talk about our sleep. And sleep can be variable, so you can have sleep where you have no trouble going to sleep, and then at 2 o'clock in the morning, you wake up. and you may have to go to the bathroom or you may not, and you just wake up and you can't go back to sleep and you're tossing and turning, you're watching a clock tick by, and you see 3 o'clock, 4 o'clock, 5 o'clock, and then you finally fall back asleep only for your alarm to wake you up at 6:30 because you have to get up and get your kids ready for school or get ready for your commute to work. Um, and then this every night, right? And so you may also have trouble going to sleep. You may kind of your mind may be racing because you're having increased anxiety, and you may not typically be someone who's an anxious person, but at this point in your life you're starting to worry more things about things, more worrying more about your kids, or worrying more about family members or projects, where usually you kind of were pretty calm and cool collected. And then the anxiety also sometimes will lead into depression. Now, I always kind of feel like if you walk or talk or breathe, at some point in your life, you're going to have an episode of some depression. But this depression is not different than a depression if you had it in your 20s, but you may not have had a history of depression. And now, as you're getting older, you're finding that you're more sad for not really anything that you can identify, or things anger you easily. Someone may say good morning and you may really just like say, I hate you, or why is it so good, or why are you having a good day and I'm not having a good day. Your filter may not be as strong, and you may say some things that are not typically you and your personality. And then you say, Did I say that?" And then what's really, really telling is when your family tells you you need to go see somebody because you're just kind of not your typical loving, compassionate self. Fatigue. Fatigue is a large one. So you may, that sleep that you're not getting in the middle of the day, you still have to function. You still have to do your executive level function. You have a career, a job, you have a house to run, you have projects or hobbies that you have interest in, organizations you want to participate in. But you may feel like you wake up and you feel like you could just really go back to sleep for 2 or 3 more hours, but you don't have that time to sleep. Or you may in the middle of the day just hit a wall where you feel constantly, constantly tired. And that could come from days of not sleeping, or it could just be baseline, just fatigue. And you and fatigue not only just in your energy level, but your muscles may fatigue more. You may be someone who likes to go to the gym and you do your exercise routines, or you like going for walking, or you had no problems climbing up the stairs a month ago, but now you climb the stairs and your legs are aching before you get to the top of the stairs. So you may have muscle fatigue as well. Again, that inability to focus. So I nickname that like adult ADD. You have, you have a list. You kind of sort of start your task list. You don't really finish it. You walk into a room. You have, you're gonna get one, two, three things out the room. You completely forgot what you went to the room for. Grocery shopping is like horrible because you can't remember what you went into the store to buy. You have multiple tabs open on your browser because you were working on 3 or 4 projects and you just really never kind of get anything completed. So that's like it's almost like an attention deficit kind of pattern. And then you may have an inability to retain information. We call that brain fog. So you may hear that term brain fog. You kind of just feel like I used to be able to have this frontal lobe. I used to be able to, remember everyone's name, or I used to be able to, do this task, pretty easily. Now it's just you're having trouble recalling things, and you're thinking, like, am I having early dementia? Like, am I having early Alzheimer's? No, it's just this menopause time in your life. Other manifestations, joint pain. So, like, we see fingers, we may see shoulders kind of get achy and stiff. Not really so much knees, but upper body joints. And then let's talk about the vagina and sex. You may feel like you are not as lubricated as you need to be, or moist as you need to be. Your underwear may be uncomfortable, or when you wipe with toilet paper, you may feel like you're more sensitive. When you're having sex, you may start off okay and adequately lubricated, but you may not be able to maintain it. You may feel like more friction, with penetration, whether it's fingers or penis or toys. And It may be really sore afterwards. You may have little micro tears. I feel like it's stinging at the end after you have intimacy. And so that all comes from menopause. You may see other things like headaches. You may have a history of migraines, and they may get worse. Some of it gets better. You may have no history of headaches and you start getting headaches. Hair starts to thin in some people. Um, Weight gain, that's a big thing, right? And that's multifocal while we have weight gain. But obviously during this time, our metabolism is slowing, and that contributes to some weight gain that we see. It may take a longer time to have an orgasm. You may need different techniques in order to reach orgasm. If you're someone who reaches orgasm, just remember 30% of women are anorgasmic, and that's just fine. Okay. You may have just decreased interest in sex. You are that coupled in that anxiety, the maybe a little depression, maybe you're not sleeping, you got fatigue, you worried about the household, and then at 11 o'clock, your partner's coming in to like pat you on the leg, and you're like, whatever, you're not even thinking about it. You don't want it. And so a lot of women complain of decreased libido for that. And they want to blame it completely on menopause and the hormones, but there's multifactorial. And we can talk about that later in the talk. Your period may go crazy. It may stop. The nice thing is if it just stops. That's nice. But mostly what happens is that you start having a regular bleeding where you're bleeding for not the 5 or 7 days you're used to, but you're bleeding out for 10 days, 15 days, or your period went off and it's coming again back in 2 weeks. And you're like, what's going on? You may have some bloating, like GI issues. Your nails may be brittle. You may have to pee more often or get up in the middle of the night and go more often. You may have more urgency and more leakage. So, all these things may happen. I think there's about 60 different symptoms that the literature is associated with menopause. And again, a lot of women are used to thinking, oh, I just have hot flash. I don't have hot flashes, therefore I don't have menopausal symptoms. But you may see that, many of these symptoms, you may be like, oh man, yeah, I know someone like that, or maybe that's me. So let's stop and talk about like definitions. Like, really, what is the true definition of when we throw away these terms? So, perimenopause is just a description of time. Okay. It's just a time in a woman's life that she can have one or more of all of those symptoms that we just talked about, but she still has not gone that one whole year without having her period. So you can be 39 and still having a menstrual cycle and be perimenopausal. You can be 54 and still having your period and be and you're and have symptoms, and you're called perimenopausal. Okay. The definition of menopause is that you have gone 12 full months. It's the time where you're transitioning and you do not have a menstrual cycle for 12 full months. Postmenopause is the rest of your life after that. So there's no like, oh, I'm through menopause. You're not through menopause until you're no longer kind of with us on the planet. Postmenopause is just the time that you've gone that one whole year. It's interchangeable with menopause. Um, and you may have symptoms. Some women have no symptoms at all. But I just kind of wanted to clarify definitions for everyone because it is very unclear when most patients come in and they have questions. All right. So let's back up a little bit and let's talk about what was the hormone pattern when you were in your 20s and 30s and having a regular menstrual cycle? Because this will help you understand what is going on now that you're in this perimenopausal or menopausal time period. So, the top graph where the circles are, that's what's going on in your ovary. And the very first day of your period, which is at the bottom, that's supposed to reflect what's going on inside the uterus. So on the very first day of your period, you start bleeding. And most women it's 7 days or less. But what during that time, what's going on in your ovary, which is separate from your uterus, is that it's working to make a nice, beautiful egg. And as it's making that nice, beautiful egg, there's a hormone called estradiol that's rising. And during your periods, most of us feel like crap, you know. We're just bloated, tired, and crampy. But usually when it's over, we start feeling pretty good. We got energy, you know, we want to, do our projects. We perform well in the gym. When estrogen is at the highest, usually on that cycle day number 14, is when that egg is ready to break free and ovulate, waiting for some sperm. You get real horny around this time because we really want to mate. And then after the body realizes, well, there's no sperm around or the sperm missed the mark, then the egg kind of dissolves, and that area in the ovary starts making a hormone called progesterone. And progesterone's job is to say, well, uterus, there might be a pregnancy coming. We're gonna keep it, stable for about a week or so, and then when we're confirmed that there's no pregnancy, I'm going away. I'm going to fall. And then that's the uterus's signal to shed or bleed, and your period starts again. So you have some estrogen going on in this 2 week window after you ovulate and between your menstrual cycle, but you kind of feel like crap. You feel when progesterone's high, you kind of feel tired, bloated, fatigued. You may, increase your water retention. You may gain a pound or two or five for some people. And so that's what's going on in your body when you are having a regular menstrual cycle. And then when you have your period starts, the cycle starts all over again. So in menopause or perimenopause, what happens is that your ovary is tired. It's just tired. It's tired of picking the egg. It's tired of growing the egg. And so it really doesn't do a good job of growing and releasing that egg. And so the brain is saying, "What's up, ovary? Like, come on, you could do it. You could do it." And it tries to stimulate the ovary. Tries to stimulate it, and it releases a hormone called follicle stimulating hormone, or FSH. And the ovary is like, okay, well, I think I can do it. And it's like, no, I can't do it. So that cycle repeats over and over again. So your estrogen levels go up and down, day to day, hour to hour, day to day, hour to hour. They go up and down. And because of that instability, we have all of those symptoms that we talked about on that second page. Eventually, the ovary just finally gives up and it's like, I can't do it anymore. I'm done. It's been a great 30 years. It's been a great ride. I'm giving up. I'm shutting down. I'm not making any more estrogen. And even and then you don't get any more periods, and you go through that 12 months, and then menopause continues on. So that's what's happening in our bodies hormonally wise. And that also will explain kind of when patients come in, they want their hormones checked because that's the first thing they think. Like, well, there's got to be something wrong. Like, I need my hormones checked. And we in our gynecology department say, yes, there is something. It's natural, but who wants to experience all this? It's not good quality of life. We want a better quality of life. But us drawing hormone labs, it's not helpful for us to help you. So people want an estradiol level. Again, we just talked about it. It changes from hour to hour, day to day. It doesn't matter what the number is. It matters what your symptoms are. So it's not helpful to check it. Your FSH, or your follicle stimulating hormone, again, it's trying to yell and scream. That number is going to be real high, trying to talk to your ovary to encourage it to make an egg or to make some more estrogen. So it's going to be high. And it doesn't tell us, oh, well, if your FSH is this number, that means your period will stop in 2 weeks or 2 months or 2 years. It tells us nothing. So it's not really a helpful lab. And then there's another common lab that you may see called LH, or luteinizing hormone, and progesterone. So in that picture where we saw the normal menstrual cycle, progesterone is not existent for the first 2 weeks of your period. And it only elevates when you ovulate. Well, if you're not ovulating anymore, then it's always going to be low. So why are we checking it? It's always going to be low. There's one good hormone that we can check for you called testosterone. It helps with our energy if we're worried about fatigue, if we're worried about our libido. That can be helpful for us so we know how to start replacement for you. But please do not spend money. I mean, if you're all, I think this forum was all KP employees members, but so we don't pay for our labs, but um, if you have friends or family that are going to specialty groups that do menopause care and they want to charge them $800. I was giving a talk. Someone said she paid $800 to get her labs checked, and I was like, that was a vacation. That was vacation, a plane ticket to a vacation for $800. Don't pay this money. It's not helpful. Outside providers get money. I mean, that's a revenue generator to do lab work, and so just we're again value based. So please don't pay for that. Okay. I'm gonna pause here to ask if there are any questions thus far about um, the what happens in our bodies and the hormones that are in play. Because now we're gonna start talking about how we fix it. Dorena, yes.
Hi, thank you, Dr. Redmond. So, I think you've named every symptom that I experience. But as far as the level of symptoms, is there any difference in how women experience it that have had like hysterectomy but left ovaries versus those that naturally go into menopause?
Hmm. That is a really good question. So when you have your a hysterectomy, and let me just really be very clear for those who are not clinical. A hysterectomy just means we are removing the uterus. The ovaries are still there. And most women, it's very confusing. They may say, "Oh, did I have a partial hysterectomy or did I have a total hysterectomy?" And they're thinking if they had a total, the ovaries are removed. Very rarely do we remove ovaries these days, unless there's really something really, really bad going on. So we try and keep your ovaries. And so women will experience maybe a few weeks after their hysterectomy, they may feel some little menopausal symptoms, but usually that doesn't shorten the age and when they will go through menopause. Now, there people will say like, "Well, how do I know if I'm going through it if I don't have a uterus, I'm not bleeding anymore?" Again, if you have symptoms, then please share your symptoms. And if your symptoms are causing you to have a poor quality of life and you'd like some help and intervention, we're happy to do that. But we don't see women who still have their uteri, we don't see them going through menopause later. Every woman is very unique and individual. You can ask maybe if your parent is still with you, your mom is still with you. If you have an older sibling that's a female, you can ask when they went through menopause. Sometimes that may kind of correlate, but it's not 100% guarantee. And it doesn't matter like what ethnicity you are. There's no ethnicity that like African American women, their symptoms are worse, they're much worse, but they don't happen younger or older. And or Asian women, they're not as bad, but they have different kind of symptoms. So it's hard to tell. Okay.
That was actually going to be my next question about is there any genetic component to the level of symptoms that you experience?
Yeah. So again, there's like an ethnic component. So the African American patients who are more obese will have worsening symptoms, or their symptoms will last longer. I think for African Americans, it that they quote an average of 10 years of symptoms. For Asian women, their symptoms are a little different. They may have more like osteoporosis risk, or thinning of the bones. They may not have as much hot flashes symptoms. Um, and their symptoms may last, a year or 2 years or 3 years. Caucasian women, their symptoms may last for 3 or 4 years. There's a movie called the M factor that we're going to be showing in January at a theater. We just showed it last week at Regional. We had a menopause um, education event, and in in that movie, you can see it on PBS as well. But they kind of break down what the data shows for the different ethnic groups. Hispanic women, they will experience more hot flashes. They'll have more sleep issues. They'll have more depression, behavioral health symptoms, but they're the group that's very quiet. They don't speak up. They just kind of suffer and suck it up and go through it alone.
Thank you for that.
Okay, so other labs that, when you go to your routine visit with your primary care that should be checked, your cholesterol. We should always get the cholesterol checked. Your thyroid, your hemoglobin A1C. You want to make sure that we don't have prediabetes. Your vitamin B12, vitamin D, vitamin B12 is low. You have decreased fatigue. That may be some of the cause of your fatigue. Vitamin D is low in everybody, so don't even ask me to check. Just start taking your supplements every day. If you take a multivitamin every day, that's also really good. But these are some things that we will check, that we should check in everyone, no matter if they're in that 40 plus age range for them. So we're going to talk about treatment options. And the first category of treatment options is hormone replacement therapy. And the second category of treatment options is non-hormone replacement treatment therapy. Okay. So pros and cons. So there was a time I remember my mom and my whole family, they all had the worst menopause. They all had hysterectomies. Their ovaries were taken. This was back in probably the 80s. And they were like, we don't want no hormones. Literally, I remember saying, I'm not taking that stuff. It's going to kill me. I'm not taking that stuff. And as you see your parents age, I really, really wish that they had. But there's so many benefits to hormone replacement therapy. So again, all the symptoms that we talked about, but there's some unseen things, right? So the vaginal dryness. I mean, I really feel like we should be having sex until we're in our 80s, right? And we need that lubrication, elasticity, that moisture in our vaginas so that it's pleasurable and enjoyable for us. Obviously, we talked about the hot flashes, mood. It's important. It helps with mood. It helps with focus. It helps with the brain fog. There's a link now of the cognitive benefits. So there's really big studies going on in neuroscience showing that um, our estrogen receptors deplete. Because our estrogen levels deplete, our receptors then go away. And the estrogen receptors are in key portions of our brain where it comes to memory and function and cognition. And so if we have supplemental estrogen, then our receptors are not suffering and it may help in cognition. So I'm really interested to see some of the data in the next 5 years, 10 years that will come out on cognition and Alzheimer's, because 2/3 of Alzheimer's patients are women. The heart protection, that's huge. So if we start hormone replacement therapy early enough, then it could be protective from heart disease, atherosclerotic disease. And so that will prevent heart attacks and strokes. We don't want to start it too late because then it'll actually increase that risk. So we don't start in women who are like 68 and 69, more than 10 years out from menopause because of that concern. And then overall improvement, quality of life and well-being, sometimes just happier. You have more energy. You feel like yourself again. So let's talk about like contraindications, okay, to taking hormone replacement therapy. And really is the main focus is on estrogen, okay? So if you are someone who has a current breast cancer, a breast cancer survivor, or you have history of uterine cancer, then you can't take hormone replacement therapy. If you've had an unprovoked blood clot in an extremity, like you were on birth control pills and got a blood clot, um, or you've had a blood clot that's in your lungs, you cannot take hormone replacement therapy. If you had a blood clot, like you fractured your leg, or you had a knee replacement and got a blood clot because of a provoked incident, then transdermal or the patch, the cream, you're a candidate for that. If you've had a previous stroke or heart attack, then you can't take hormone replacement therapy. Coronary artery disease, we talked about that we don't want to start it in women who are really older because they may have really bad coronary artery disease plaque. But for some of our younger patients, it might be worth a conversation with the cardiologist to say, like, really, how bad am I? Is this something that is my risk like 2% or is my risk like 20%? Like, really, what's my risk? And have that conversation to see if it's an option for you. If you have a blood clotting disorder, which means that you have a predisposition to have blood clots in your legs or your blood vessels in your brain or your arms, and you know who you are already if you have this, and then there is a calculation that we do for all women, and we look at it's called atherosclerotic disease risk. And it basically looks at your age, it looks at how much you weigh, what your blood pressure is, what your glucose levels are, do you smoke, what your cholesterol levels are. And it does this calculation, and it says in the next 10 years, Miss Martha has a one 0.7% chance of having a heart attack. Or it'll say Miss Martha has a 5.7% chance of having a heart attack in the next 10 years. Those women who have a risk that's over 10% cannot take hormone replacement therapy. If you have under 10%, like 5 to 10%, you can do a transdermal, like a patch or something. But if it's over, then you cannot do that. Smoking for is not a contraindication, but I tend to lie to get my patients to stop smoking. I'm like, oh, you gotta stop. We have to get your nicotine patch or something because you can't have these HRT if you smoke. So, but it is not officially a contraindication. And all of this does not apply to vaginal estrogen. So, again, there's new information that has come out in the oncology space that they're allowing our patients, and it's case by case basis, to use vaginal estrogen if they have, a history of breast cancer and they're out a certain amount. I mean, it gets case by case, and I really just consult with the oncologist and let them decide. There's lots of other options for us for vaginal dryness, but if you don't have history of breast cancer, anyone can use transvaginal estrogen, and I really kind of hand it out like water. I'm like, do you have sex? Here's some estrogen. Do you have sex? Here's some estrogen. It helps with incontinence as well. All right, so what are the types? Like, what are the types of estrogen, like the roots, right? So I get this question a lot. So estrogen can come in a pill form. It can come in a patch, and that patch can go on your arm or your belly. And there's a patch that you change once a week. There's a patch that you change twice a week. That is not on our formulary. The twice a week patch is smaller, it's cuter. Um, there's a cream that you can get compounded from a compounding pharmacy. There's a estrogen mist. There is a gel that you can use. Those are not on our formulary, so you may have to pay out of pocket or use a compounding pharmacy for that. I get lots of questions about implants or um, implants. The pellets they're also called the pellets. And so what I'd like to say, the pellets are you can put multiple things in the pellet. You can put estrogen and testosterone in the pellet. And basically a provider has a little insertion device that they put in your butt cheek, and they deposit the pellet. So the pro of the pellet is that you don't have to do anything. The pellet is there, it just does its thing, and you live your life, and hopefully, you are that person who has the perfect dosing, and it lasts for 6 months. The con of the pellet is that one is expensive because you have to pay not only for the actual medication, but you have to pay for the visit for the consultation, and then you have to pay for the visit for the insertion. The other thing is that we can't regulate the dosing or your personal absorption. So once the palate is there, if you're someone who's a really super absorber and you start having high testosterone levels and you start growing a beard, or you have a libido and we have to have the police come to your house to save your partner, I mean, because your testosterone level is 300, we can't get that out of you. You have to wait till it wears off. And vice versa, if it runs out before your 6 months is up, then you have to wait. You have a crash and you have to wait until you pay more money. And so pellets can be upwards of $300, 200 to even $600. So that's just my spiel. There, I'm not saying they're good or bad, but those are just some of the pros and the cons. And we don't do pellets in our women's health department here at KP. Um, Birth control pills are also an option. There's some women who are still having their menstrual cycles, and so we will do birth control pills to give them that estrogen back as well as regulate their cycles. Okay. And we already talked about who should avoid it. And then we're going to talk about some alternatives coming up in the next little segment. So I want to talk about the word bioidentical. What does that mean? Right? So bioidentical just means that the medicine that you are taking has the exact same chemical structure as what your body makes. A lot of um, marketing, because we are a value-based entity at Kaiser Permanente. The rest of the world is fee for service. So they have to make revenue in order to run their business. So there was a culture that made women think that bioidentical needed to cost more money. And they needed to pay for something special. They needed to have to pay for something compounded to be made. And they needed to go to this, core group of doctors to get their bioidentical hormones. And they needed to pay $200 a month for have that done. So we got all kinds of bioidentical stuff on our formulary. That's your $10 copay or your $15 copay. So that's just all what that means is it just means the same structure, but it's been kind of used as a marketing term where it shouldn't be used. So estradiol, that hormone that we talked about in our graph of our normal menstrual cycle, that hormone that's going erratic, it's up and down and up, day to day, hour to hour. So that is actual bioidentical, and that comes in a pill, comes in a patch, it can come in a compounding cream, and that's usually probably 90% of what is given back for hormone replacement therapy. Um, the estrogen, when you still have a uterus, we have to give you progesterone hormone so that estrogen doesn't stimulate that lining and cause it to grow, or and progesterone keeps the lining nice and thin. So progesterone, it comes bioidentical. So we have, but it also comes in a lot of different non-bioidentical forms. And I don't want women to get hung up on, I only have to have bioidentical, because you may in your brain think that's best, but your uterus and your periods are like, no, baby, we gonna bleed and we're gonna laugh at it. And so the progesterone is what's keeping you from having a regular bleeding, prolonged bleeding, heavy bleeding. And so progesterone may need to come in a different form than the bioidentical form in order, depending upon where you are in your menopause journey. So we can do a pill. We don't have a progesterone patch. We have an injection, like Depo-Provera, a progesterone intrauterine device called Mirena, is really convenient. You just put the IUD in and you put on the patch, you just keep it moving. You don't have to worry about it. They last for 8 years. Some people are kind of squeamish about having, something like an IUD placed. So you then you stick with your pills. Um, and we often use it for, like I said, sleep and abnormal bleeding. Or if you're no longer having a menstrual cycle, then you need it to protect your uterine lining. Because if you take estrogen by itself, you may start bleeding. And even if you take it with the progesterone and bleed, don't get scared. We just need to adjust the progesterone and we need to find the progesterone that your uterus likes. So, testosterone. Not all women need testosterone. I think we underuse it though. Um, Again, it can come in a prescription. We do have a pill that has estrogen and progesterone mixed together in it. The estrogen is not bioidentical, but we do have one that we can use. Um, Testosterone often it comes, there's not a female form that is FDA approved. And that's, unfortunately, the frustration that a lot of physicians have is like, you got Viagra from these men. Like, why can't a pharmaceutical company make a testosterone that will be covered by that will be FDA approved and covered by our insurance so that we can get testosterone as well, so we don't have to pay so much money for it. Right now, there's a gel called androgel, and it's just very like it's off label. It's for men. And I have to tell my patients, well, use half a pump, not the whole pump, because the milk dosing says 1 pump, 2 pump, 3 pump, 4 pump, 5 pumps. I'm telling my patients you can use half a pump, and then we got to check your levels in a month and then or 2 months to make sure you're not using too much. And if the level of testosterone is too high, then I'm like, okay, we got to do it. So I have to jimmy rig it too much. And that's not fair, I feel like, for women. Um, we can also use compounding, but that's expensive. Compounding medication may be $30 or even, $60, for some of the medicine a month. And I feel like if you have insurance, you have a $10, $15 copay, it should be covered. But what do we use it for? We use it for energy, fatigue, that muscle wasting, and libido. So we talk about the weight gain that women experience, and I want to circle back to that because there are going to be some questions about that. So weight gain happens for a few reasons, but one of the reasons of the few is that we start to lose muscle. If you are not strength training as part of your weekly routine of exercise, the muscle that you have will deteriorate. Muscle but is a higher metabolizer than fat. It means muscle works harder in your body at rest. And so if you lose muscle, then your metabolism isn't as strong as it used to be. And so you may need some testosterone or you may need to incorporate weight training. So strength training with hand weights, your calisthenics, chair Pilates if you're not that strong, real Pilates if you're really strong, um, yoga, things like that to keep and maintain the muscle that you have. So now let's talk about non-hormonal treatment options because not everyone wants to take hormones or not everyone can take hormones. Okay. So we use a lot of things in medicine off label. Um, and so antidepressant category of medicine, and you see I mean, I just listed five. There's probably many more that we use for in the realm of depression that help with menopause symptoms. It works on the same centers in our brain where the origination of hot flashes and sleep issues and anxiety occur. So Wellbutrin is a common one, Paxil, Prozac, Lexapro, Effexor. And you may say, I don't want to be on an antidepressant. You may want to not associate that stigma. I'm going to tell you to get over it because you're not depressed. I don't want you to feel like because someone or someone in your family sees that you have a bottle of Effexor in your purse, like shoot, treat those hot flashes. They're not the ones not sleeping at night. They're not the ones that have, you know, hot flashes and have to step out the room and unbutton your shirt and fan and get and walk around with a fan. They're not experiencing this. So don't worry about what other outside people may think if you are taking antidepressant. It works for many women. And even if you're on hormone replacement therapy, you may have a behavioral health component to it. You may have downright depression. You may have anxiety, and we need to put you on both, and you may feel so much better because you're on both. So antidepressants is a common one that we use. Another is called gabapentin. Gabapentin is usually a nerve pain medication. We use it for, we call that neuropathy, but it does decrease hot flashes and night sweats, and it may improve your sleep. And so this is a good one that we use in patients who have breast cancer, um, or history of having a blood clot, or who just, who don't want to take hormone replacement therapy. And again, we may use it in combination with an antidepressant. There's a class of medication called SERMs, or SERM. They work actually on the estrogen receptor, and modulate it, so that will help some of those symptoms. We use SERMs a lot for people who have thinning bones, who have a diagnosis of osteoporosis, but it also will help some menopausal symptoms. And we mix like estrogen with the like this one called beta-doxyphene, and it's mixed with estrogen, and we use it for that. So, and there's a blood pressure medicine called clonidine I didn't put on here because some, it it has some good effects with it. It helps manage your blood pressure, but we only use it for people who have high blood pressure and menopausal symptoms, and we really don't want to start the hormones because their blood pressure is really crazy out of control. So we may use a clonidine, but it also has some issues with stopping the clonidine and rebound blood pressures and stuff. So I just left it off. So let's talk about herbs. All right. So do I use glycopyrrolate for hot flashes? I'm gonna look that up. So here on this slide, it says there are many things, many herbs that can be used for your menopause symptoms. There's more here than I've out there that I've listed. There's more that I probably know about. So if you are in a menopause Facebook group or a community, or y'all sitting around talking and you friends, and they say they tried this and tried that and it worked for them, and you want to try it, sure, that's fine. Um, Touch base if you are someone who has a lot of medical issues. I would just kind of shoot your doctor a note just to make sure nothing's going to interact. But try it, because we don't have all the answers. We don't know. I know what I use. I know what recommend, but I, only know my patients. I mean, it would be great if we had a great collaborative of really of things that are out there that may work. And just know that there's a placebo effect. 30% of women, like you would take 100 women, you start them all on some kind of herbal something, 30% are going to get better. And it from just a placebo. Like if you gave them a placebo, they'd be like, "Oh, this is working. I'm feeling really good." So placebo works 30% of the time. So if you start with maca and or estrogen and black cohosh, and you're like, "This is working really well," and then it stops working, not that, it didn't help you, but maybe as you got further along in your menopause journey, you needed a little bit more support, or the facts just kind of basically just no longer work for you. You can try and mix hormone supplements. I can say the top three, the maca, estrogen, black cohosh, really work. The bottom three, eh, ashwagandha is always good for your mood. Evening primrose is plus minus. There's no amount of yam or soy that we know to tell you to eat or consume to help with symptoms. You may need a gallon of soy milk. I mean, I don't know, a day. There's no studies on how much that's needed. So those are things are kind of up in the air. And then really, 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 it's important. Many of us kind of, as we were younger, like maybe we weren't athletes, right? And maybe we just looked good, we were cute, and you didn't really need to exercise that much. And then as you got older, the hips look good. People are like, oh, your hips look good. Or your boobs got bigger. You're like, oh, I finally got some boobs. There's gonna be a point in time where you have to move. You have to exercise for several reasons. So one, your metabolism is slowing. And so you're just going to get bigger and bigger and bigger. Two, you're going to develop some kind of insulin resistance. It could be low key, it could be high key, you could be pre-diabetic. But if you develop that insulin resistance, you're just going to gain, I mean, your body is in storage state. Your insulin levels kind of stayed a little higher and it's just constantly in a storage state. So even if you feel like I haven't changed any of my eating habits and I'm still gaining weight, or I haven't added any, I still walk my same, 2 miles around my neighborhood and I'm still gaining weight. You have to pay attention to that strength training exercise. The other reason why you need to move is because your joints are going to get stiff, your muscles, your flexibility, your ligaments are going to get stiff. And when you are, 40 and you trip, you might be able to right yourself. You might be able to catch yourself. But when you are 75 and you trip, you're going to fall and fracture a hip. And then you're going to have to have surgery. And then you have to go to rehab. And then you're going to for a blood clot. And then you're going to like die. So, no, we want to live till we are 100. So, move. If you get nothing out of this, I want you to go home and start your exercise plan for movement, stretching, whatever tomorrow. Meditation. Get the Calm app. Get the Calm app. Get the Calm app. If you can't sleep, get the Calm app. If your coworker who said they was gonna have this project done, and they didn't have the project done, and you got to stay up till 2 o'clock in the morning to finish the project, and you pissed and you mad and you need to have that crucial conversation, get the Calm app. So, meditation is very helpful during this time because your patience is not there. You get a whole lot of wisdom as you get older, and you really kind of start to realize I don't have to deal with other people's crap. So reach out for social support. You are not the only one going through this. I've heard so many times women say, I didn't know. I thought it was just me. I had no one to ask. I didn't have anyone to, tell me. No one's telling, like, why didn't anyone tell me this? If you Google in any kind of social media platform, any kind of social group, any kind of friend and say like, "Have you experienced any of this stuff?" Then they're gonna say, "Yeah, I do." And you can be each other's buddies and then you pull more buddies in. But being able to have a community will help you get through these times, okay? So those are just lifestyle adjustments that I think we should all kind of implement, regardless if you have symptoms or not, because I feel like as we age, like life just is getting harder and harder to manage because we're now responsible for ourselves, our careers, our kids, our parents, our family members, and it just gets hard. So, and then if you get some hobbies, have an outlet, have a passion project, do something that kind of makes you happy, that takes the stress away from you. All right. So, oh, good. I got it. I got kept us underneath an hour. And so now I'm going to stop sharing my screen and I want to just give some time for people to ask more questions. Stop presenting. Wait, okay, this will end the preserve for everyone to switch presenters. Okay, so I'm going to stop presenting and then hopefully we just go back to regular teams. Yeah, I did it right. Okay, thoughts, questions. Miss Dorena.
Well, you know, I have 10 million questions because we go through this all the
Great.
time.
Mhm.
So, is there ever going to be a time where all of this is going to stop if I take nothing? Like, does menopause stop at like, for instance, my mom has no symptoms whatsoever. She never took HRT, none of that stuff, but she's great. So, does that happen? Does the hair start getting fuller again, or is it gonna stay thin without medicine? Is there a natural fix?
Right. So you could do you can do symptom therapy. So if you're worried about hair thinning, go see your friendly neighborhood dermatologist. They have all kinds of Rogaine and
Mhm.
things that will help the hair. But there's every woman is unique. Her journey is going to be unique and different. A woman may have symptoms for a year or two and then she's good or she's developed coping skills for them. A woman may be 70 and still have still have symptoms. So there's no answer that okay, in 10 years you're going to be done or you're going to be through with symptoms. It's just really person by person. And the symptoms that you experience are going to be unique, and what's important to you or what's the most impactful or impacting your quality of life is going to be specific to you.
Okay, that makes sense.
What else? I'm gonna look up that medication that someone put in the chat about the um glyc about the that supplement. April, yes.
So that medication, glycopyrrolate,
Yeah.
I learned that from one of my patients. She was telling me she was taking it for hot flashes. And then I realized it was the same medication that my daughter was prescribed for excessive sweating. And
Oh,
so I asked my gynecologist if I could try it for the hot flashes. So when you take it, it does stop the sweating, but I still feel the sensation of the hot flash. So I feel that I call the sensation like it feels like when you have the flu, you feel really achy at first, and then all of a sudden you start feeling hot. But I never sweat. And so it helps me at work because I can take one pill like a week and I'll feel hot, but I never sweat.
yeah.
And I take it when I go to the beach as well.
Oh, nice, nice. So this medicine, I just looked it up. It's a what we call an anticholinergic drug. So basically, it just means it affects your sweat glands. And so yes, yeah, it just keeps you from feeling it may dry your mouth. Do you have dry mouth too? Because it affects your salivatory glands too. Do you have
Yeah,
dry mouth
so
with it?
like I said, yeah, I only take one. I might take one or two a week because it
Hmm.
says on the bottle to take it 3 times a day. But when I first got the prescription, it makes you feel like you have a sore throat, like you're coming down with something. And I didn't like that sensation, so I just take like one or two a week if I need it.
Right, right. So what April's saying that for her symptoms, it was the most thing that was impacting her was sweating, like in front of her patients or sweating like on the job. And so she did something that was more system focused or symptom focused, which was the sweating. And she says, "Well, I can suck up. I can deal with the thought, the feeling hot. I can deal with that." And so that's a really good solution, April. I'm gonna keep that one in hand. And so again, if alternatives to hormone replacement therapy or some of the other things that we listed there. So thanks for the add it to the toolbox. Oh, okay. So someone joined late and they said, let me actually open it first. Oh, so we're recording. So I'm gonna post the recording and or you could go back and you can see the whole thing afterwards. Yeah.
Hi, Dr. Redmond. Great presentation. I
Thank
do.
you.
I have a question. I'm not certain if we did touch on this, but should it seems like now there I shouldn't really necessarily be concerned about a family history of breast cancer. I can still do like a transvaginal hormonal replacement product.
Correct, correct. So it's so having a family is history is not a contraindication. Obviously, you've already talked to your primary care doctor or your gynecologist about your family history. We've kind of figured out, are you a high risk patient? Because maybe you've gone to genetics, and then if you are risk over 20%, then you get so April. And so, but if you don't actually at the time, if you personally do not have a history of breast cancer and you get your mammograms regularly, you can do hormone replacement therapy. If you're that high risk person, then it's a conversation. Not that you can't do it, but I just think you should have a discussion and decide, like, your hot flashes and your quiet of your life is your 100% reality. That's every day, your 100% reality. Your risk for your breast cancer is what was discussed, with the geneticist person. And so you have to decide what's best for you. But like all the time, people's, oh, my grandmother had breast cancer. And I'm like, I'm really sorry that your grandmother had breast cancer, but you don't have it. Therefore, you're still a candidate. Raquel, did you have a question?
Yes, and I had a comment. Thank you so much.
Yeah.
It's we're all talking and talking more, and we need to talk more because each one can teach one,
Hmm.
and not be afraid. So I appreciate you doing this for us. In regards to um the medication that you may be on now, over time, will you may need to do adjustments. So we just need to be in constant conversation with you when we notice things that are changing to either adjust or maybe try something different.
Absolutely, absolutely. So if you're starting on anything, so the first time that we start you on something, Raquel is unique. We're not going to know how Raquel is going to respond or if the doses are going to relieve all her symptoms. There's no magic bullet and there's no kind of roadmap to Raquel. And so I like patients to give me feedback in a month. How are you doing? What symptoms are you still having? What symptoms do you want it improved? Are you having some side effects? Not a lot of times, but often, if you're really close to menopause, like you just stopped having your period within the last year or two, and you may have some spotting, and that freaks people out. And so we have to do like a quick, workup, and adjust the medication, so that you not have bleeding, but you still get some benefit. You may, as you get older, your symptoms or you may start out and your symptoms aren't as bad as what they may be in a year from now. And so your doses need to change, or they may get better over time and we can go down on your dosage. So it's always a conversation. And usually, we're touching base within the first like 6 months, we're touching base a lot. And then we want to see you every year because you don't get your refills unless we talk. Because I need to make sure you had your mammogram. I need to make sure your cholesterol is good. I need to make sure your heart is good. I need to make sure your blood pressure is good. Because we just don't want to give it and just you go out and then something untoward happens.
So, Dr. Redmond, there's a question about brain fog. And the second question is, are we considering creating a department for menopause care?
Who wants to write a business case and give it to my boss? I would totally, I would totally do a menopause clinic. We need it. I just looked at my schedule. I have a virtual schedule on Thursday. Sometimes we get virtual schedules, and it's just filled with just menopause patients. Not to say that I'm some unique person, but I just think that the conversation is out there, and women are looking for answers. And I did a education CME for my department as well as the Department of Adult Medicine because we were just behind. We were behind in our fund of knowledge, and our patients were in need. And so I think, more providers are learning or a little bit more comfortable, but I truly believe that it would be helpful to have, one place where our patients can go because it takes a longer time to talk. Like we can't do this in 20 minutes. We just can't do it in 20 minutes. And then what can we help with the brain fog? So if you're open to hormone replacement therapy, that estrogen will clear it right up. I mean, it will help. Sleep, we can get you sleeping and getting a little estrogen replacement. The brain fog will clear up. If you wanted to do something that's not hormonal, um, I don't have a magic bullet for it. We may have to just do more cognitive like therapy, more mindfulness work to help develop some tools to make you at least a little bit better. Like if you like rhyming, like rhyming, you can't remember somebody's name, so come up with like games to help you remember names. So maybe you need to go see our behavioral therapist or to help with that. But estrogen really, I feel like it just really solves it. I mean, I have personal story. I really thought that I was, just this is it. I'm no longer bright. I can't remember 6 digit. I cannot remember a phone number. Could not remember a health record number. I could not remember the 7 digit health record number. I would have to go back 3 or 4 times to check the number if I was writing it out or typing it out. I could not remember it. I could not stay awake if I was at the hospital. I would go in, I would start the day. I wake up at 5:30. I get to the hospital at 7. And by 10 o'clock, after I did morning rounds and made sure no one was crashing, I had to go to the call room to lay down and take a nap. Like I would, if I had a meeting, I'd be like, no, let me, I need a nap. Like it was really, really that bad. And I was like, what's wrong? Like, what is going on? I couldn't get through a exercise class. I couldn't sleep. And I went to my primary care doctor and I said, I need some extra. Like I just and he gave me that person. I ran straight. I use compounding estrogen because that's just what I like to do. I like to put on a cream. I will not remember to take a pill every day. Um, and I ran to that compounding pharmacy and I sat there and I got in the car and I immediately put it on like it was crack. Like, give it to me, give it to me, give it to me. So, so I really truly, needed the help. So I understand um, um, the need for our patients, but it's very helpful. Billy's like, that's me. Okay. Yes. All right.
What should I say to my sister about the FDA warnings she's seen on the packaging for the HRT
So I
medicine?
mean, you if you want to, if you can share this talk, you can. So the FD the hormone tell me specifically which packaging she's talking about. But again, there's risk when you take hormone replacement therapy, and the risk is if you take estrogen and you don't take any progesterone with it, you have a risk of developing bleeding and overgrowth of the uterine lining and possibly in the future endometrial cancer. So that's a risk. If you any supplemental estrogen that you take, no matter if it's a birth control pill when you're 16 or you're pregnant or you take hormone replacement therapy, there's a risk for developing a blood clot. And you're like, it's very rare, but it's a risk. If you don't get your mammograms, and there's a breast cancer there and it has a receptor to estrogen, it may stimulate that breast cancer. So there, if you have cardiovascular disease and you have high blood pressure that's uncontrolled, it may cause you to have a stroke. I mean, there's risk. So the FDA's job is to write that on every prescription. It's your sister's hopefully wisdom that she goes and she talks about, well, what's my risk for me? And talks to a provider who will be very thorough and listen and know her history and give her honest answer. So,
Thank you. That was very helpful.
all right, ladies. This has been great. There's again, I wanted to do this for the KPP, but we didn't really advertise it like we should have. I finished our event last Monday and I was just like, I didn't get to say everything I wanted to say last Monday. That was a different kind of event. So I wanted to have opportunities for our KP teammates to come and just talk because I know you guys are going through it. I know it's hard to get um, in quickly to see people in our departments at the end of the year. Everything is tight and crazy. Access is bad. So I just want to create an opportunity. And then I just kind of wanted to trial run doing something like this. I'm going to schedule another one of this, and this is going to be for the public. We're going to just advertise it. Just anyone who sees the links can log in. They're not going to be KP members, or they're just going to be just the public. And then we're going to do an in-person the team that did the M Factor movie last week. Kaiser just gave it KP just let them use the space, but I'm gonna work with them and we're going to have a video, another like movie theater screening of the movie, and then do like a discussion like this afterwards. So more to come, more to come. And thank you guys for joining us this evening at 6 o'clock. I hope you'll have a great rest of your week. And, text or call, chat, whatever. I'm around. Y'all know how to find me. And write that business case for me so I can have menopause clinic, y'all.
I'm on it.
All right.
Thank you,
All
Dr.
right. Awesome.
Redmond.
All right. Have a great evening. Bye-bye.
Bye.
Good night.
Good evening.
Thank you
Bye.
so much.
Bye.
Thank
Thanks.
you.
Good
Bye.
night.